20 nail dystrophy, but it's believed that this term, however, is not appropriate anymore and must be abandoned, as the dystrophies do not always involve all the 20 nails. It's more frequent in children, where it usually affects all the 20 nails, but it can occur also in adults and affect just few nails. As you can see from this picture, just 2 nails are affected by the disease. The average age of onset is 3 to 12 years old. So, as I said, it's very common in children. It's more common in children than in adults. And fingernails are affected more often than toenails, even if toenails are more severe. So the disease in the toenails, probably due to the trauma in wearing the soles, is more severe. There is a male preponderance in children and a female preponderance in adults. Clinically, we talk about trachonicia as a sign when the nail plate shows thinning and, above all, roughening due to multiple longitudinal ridging and superficial scaling. Hyperkeratosis of the cuticle is often present. Also, koilonychia may be associated, and it's a painless sign. So there are no associated symptoms. As I say, trachonichia is a sign. I repeat this multiple times because it's the clinical result of an inflammation affecting the nail matrix. Basically, there is an inflammatory insult to the nail matrix keratinocytes that impairs their maturative and differentiative activity without interrupting the mitotic activity. So there is no interruption of the mitotic activity, there is no onychomadesis, no breakage in the nail plate. Moreover, onychocytes retain their nuclei, and instead of maturing to form a compact layer of tightly adherent flat cells, they produce a stratum corneum-like layer that easily desquamate at a minimal trauma. The inflammatory infiltrate can be severe or less severe. The more severe is the inflammatory infiltrate, the more rough is the clinical presentation of trachonicia. As I said, the toenails are usually more severely affected than the fingernail. This is a case, this is another case, and these are two pictures showing you the hyperkeratosis of the cuticle and also a slight trachonicia that commonly presents together with the nail surface abnormalities. And remember, the nail plates are brittle. There is an easy breakage. It's like the superficial layers of the nail plate are sandpapered. Onychoscopy can be useful in evaluating trachonicia, even if trachonicia is a clinical sign. But as you may know, the dermoscope is a magnification lens, so you can better see what your naked eye is able to see. The diagnosis of the causative disease requires a biopsy. I told you before that trachonicia is a sign of an inflammation in the matrix, but we don't know which is the inflammation without performing a biopsy. So trachonicia can be a sign of idiopathic inflammation, alopecia areata, lichen planus, psoriasis, eczema, atopic dermatitis. But also a lot of other diseases that are inflammatory diseases can manifest with trachonicia as a sign. You see here the list is very, very huge. The point is that trachonitia is a benign disorder. So most of the time biopsy is contraindicated, especially because children are those mostly affected by trachonitia. So it's not necessary to bother them with a biopsy because sometimes revealing the diseases is not so important. However, if we want to perform a biopsy, we could find at pathology a spongiotic pattern that is the most common pattern, is the pattern typical of eczema or atopic dermatitis, and the pathologist can tell you what he is looking in the matrix, but also in the bed, because usually even if a punch biopsy in the bed, if possible, or in the matrix are less traumatizing than a longitudinal biopsy, the longitudinal nail biopsy is better to reveal the disease with all its potential. Maybe it could be in the future possible to make a certain diagnosis through the nail clippings. You know, you can clip the distal part of the nail plate and perform the diagnosis of psoriasis or onychomycosis. Maybe in the future, if we clip the trachonitia plate, we will be able to diagnose the causative disease. At present, more studies are necessary, more samples are necessary to validate the preliminary results. Psoriasiform pattern is also a possibility, so trachonitia can be an expression of nail psoriasis. Sometimes the clinical presentation is enough to tell you that you are facing psoriasis. As you can see in this patient, there is pitting. Irregular pitting is common of psoriasis, so you can say, even without a pathology, that you are facing nail psoriasis. Same with lichen planus. Trachonitia can be a presentation, a clinical presentation of lichen planus. Trachonitia is also a clinical presentation in alopecia areata. So, especially children, it's very common to have alopecia areata of the nail presenting as trachonitia. Even in adults, it's possible, but in children is much more common. But having alopecia areata and having trachonitia, it doesn't mean necessarily that you have alopecia areata of the nails. There are cases in the literature described where patient has alopecia areata of the scalp and lichen planus of the nails presenting as trachonitia. The treatment, as I said, is a benign and painless condition, so if it's not so bothersome for patient, you can decide even not to treat. Maybe it's better to start, if you want to treat, with topical agents, especially because most of the time you will deal with children, but you can also go for intralesional steroids or systemic agents. The point, the choice of treatment depends as usual on age, associated disease, and severity of nail changes. So you have to discuss with your patient first which is the best treatment for the case you are dealing with. Steroids are probably the first line treatment, topical and intralesional. There is an improvement of the disease, but if I may say, from my experience, trachonitia maybe is a mild inflammation, but it's very stubborn. It's very difficult to obtain good results. That's another case. And it is a case treated, more than a case, sorry, 37 cases treated with alitretinoin. Alitretinoin is an oral drug, not available in all countries, is a retinoid with less potent, it's less potent and has less side effects compared to acitretin. So, since acitretin and retinoids in general are responsible of thinning the nail plate, since patient with trachyonychia has already thin and brittle plates, maybe alitretinoin can be a good option for them instead of acitretin. But if you want to go for acitretin, it's an opportunity. It's better to keep the dosage per kilo low, so maybe 0.2 milligram per kilogram is the better dosage for those patients. As I said before, you can have two diseases in a patient. So this is a case of alopecia areata with nail lichen planus. Both diseases cured thanks to tofacitinib. So JAK inhibitors are an opportunity for patients with trachyonychia. I recall you that the disease is supposed to be recalcitrant or severe because these drugs potentially as side effects, and what we know so far is that the treatment must be continue over time, because otherwise if you stop the drug the disease recur. So maybe the topical JAK inhibitors that will be soon marketed, some of them are already marketed for vitiligo and hand eczema, may be a good option. So thank you so much for listening to me. I take advantage of this presentation, if I may, to invite you all to the Nail World Day that will be held on February 8, 2025. You have to subscribe to Global Dermatology. It's free, and then you can attend a one-day meeting on nail health and disease, and you will find there many experts online to teach you about nail pathology. Thank you so much for having me. Waiting for your comments.
Greetings to my listeners. In this Guinea World Skin Health Day celebration, I'll be speaking in the nail session on the topic onycholysis. What does it tell us? I bring you greetings from the Nail Society of India, and I have no conflict of interest or financial disclosures. Onycholysis is basically a simple word for the separation of the nail plate from the nail bed. It's a common presentation of various nail disorders affecting all age groups and genders. It's a very common nail sign, but its etiology differs largely. A minority of the cases may be primary onycholysis, but most of the cases are actually secondary onycholysis, where onycholysis is a pointer towards a nail bed disease, including onychomycosis, nail psoriasis, lichen planus, or even drugs which may induce onycholysis. Through this session, we should be able to appreciate the various etiological factors for onycholysis, recognize its clinical and onychoscopic features, onychoscopy being able to tell us many subtle changes pointing towards the diagnosis, advise appropriate investigations, and perform a nail biopsy and histopathology whenever required, because that is the diagnostic gold standard, all with an aim that we institute an appropriate treatment for these cases so that we can implement effective maintenance strategies to prevent permanent onycholysis. Onycholysis is a basic clinical sign, which is one of the commonest, usually begins in the onychodermal band, though it can be proximal also. The central distal part of the nail is usually involved, though we know lateral onycholysis as well as proximal separation of the nail plate. It is frequently encountered in day to day clinical practice, occurs all across the world, but has a clear predominance in the female gender. Certain occupations, including housewives, food handlers, those engaging in wet work, are more predisposed. Onycholysis may be acute onset or may be chronic persistent. The common factor being that onycholytic nail becomes opaque, losing its typical pearly color. And in fact, the color is able to tell us a lot about the possible etiology of this onycholysis. Most of the patients may have no symptoms, but those who complain of symptoms often complain of a discomfort, especially while unbuttoning their clothes or performing daily activities like opening cans or even writing or picking up fine objects. In a minority, it may also be painful, though majority do not complain of any pain. It's a significant cosmetic concern, and the patient has a fear of further breakage and nail loss. On examination, you see a disruption of the regular semilunar shape of the onychodermal band, which is the defining sign for onycholysis. Now, this separation can be of various extent and various types of borders. The nail surface may be normal or may give you clues towards the etiology. The subungual debris are of varying quality, quantity, and color, all giving clues towards its etiology. Acute onset onycholysis often has a hemorrhage associated with it. Based on the severity, it's classified into 5 stages, characterized by an early stage 1 of 1 to 2 mm separation, stage 2 progressing up to distal 1/3, stage 3 where it is occupying 1/3 to 2/3 of the distal nail plate which is separated, stage 4 which is in fact onychomatosis or proximal separation of the nail plate, and stage 5 which is the irreversible stage or what we know as the disappearing nail bed. So this could be stage 1. Stage 2, where you see more than one third or near about that the nail plate has separated. Stage 3, where it is more than 2/3. Here you see onychomatosis, a proximal separation of the nail plate occurring from the nail bed. And this is the disappearing nail bed because of this keratinization of the nail bed. So even if the nail plate grows back, it is unlikely to attach to this keratinized nail bed. It is seen if an onycholysis is allowed to persist for long, and the nail bed here is going to start developing dermatoglyphics. Based on morphology, also we can classify onycholysis into the transversal onycholysis, the lateral onycholysis, a circular onycholysis, and a V-shaped onycholysis. These things are better appreciated on onychoscopy, where the transversal onycholysis can be of many different types, including the linear transversal, roller coaster, fibrillar transversal, serrated transversals, or proximal erythematous border transversal. So all the figures are in fact self-explanatory. Now, we talked about the types, either it's primary or secondary onycholysis. These are the different causes which we associate with different types of primary and secondary onycholysis, notable being photoonycholysis, which is often drug-induced or may also be seen in patients with porphyria or pseudoporphyria. Onychomatosis, that is the proximal separation, also has these causes which have been reported in literature. Different types of onychomatosis is seen. Talking first of primary onycholysis, it's also known as idiopathic onycholysis or simple onycholysis, and it's a common condition. We only fail to recognize it easily. Onset is generally in adulthood, though any age group can be affected, and it often occurs because of repeated wet work and is commonly seen in homemakers. It's characterized by a particularly non-inflammatory type of distal onycholysis, not associated with distinctive changes either in the nail bed or the nail plate. The separation tends to be linear transversal type. The etiopathogenesis is not very clear whether this is truly idiopathic or is a manifestation of irritant contact dermatitis, but many parallels have been drawn with the condition chronic paronychia, and similar kind of treatment works here. So it's common in patients with hand dermatitis, and there is a good response to topical steroids. And strict irritant avoidance can potentially normalize these nails. Exposure to irritants, exposure to embedded foreign material, prolonged immersion of hands in aqueous solution, and even the role of yeast has been implicated. Mechanical separation, physical trauma, etc., are also known to cause this. When in toenails, it's often implicated on ill fitted footwear, keeping nails long, or engaging in contact or traumatic sports. Secondary onycholysis occurs in the presence of known causative factors. These include infections, especially onychomycosis, which happens to be the commonest cause of onycholysis. Here you see the characteristic color changes and the characteristic proximal serrated border of distal lateral subungual onychomycosis. It's seen also with Norwegian scabies, subungual boards. Pseudomonas or chloronychia is another infection which is associated with onycholysis, but whether it's a causative factor or it is just a secondary colonization with Pseudomonas is something which is which is open to debate. Here you see the characteristic greenish yellow discoloration which suggests Pseudomonas as the associated factor in onycholysis. Among the dermatoses, psoriasis is the commonest cause of onycholysis, affecting more fingernails than toenails. And it is characterized by a linear transversal band with a characteristic proximal erythematous border, which suggests disease activity as well as suggests psoriasis as a cause of this onycholysis. Here you see multiple splinter hemorrhages associated with it. Onychoscopy will show you the presence of the keratotic pits as well as this proximal erythematous border being composed of multiple dilated vessels, splinter hemorrhages. Lichen planus is also associated with onycholysis. The characteristic features here are going to be the longitudinal melanonychia in a number of nails. The onycholysis here can have both a straight edge or even a jagged edge. The erythematous nail bed, a manifestation of a thinned out nail plate, is often associated. Erosive lichen planus is a special variant of nail lichen planus, which is characterized by erosive changes in the nail bed. So there is an acute inflammation. This is a potentially scarring condition and needs early institution of steroid therapy. Lichen striatus in a few reports has been associated with onycholysis, which is characteristically laterally placed and affects a nail in the line of the lesions of lichen striatus on the skin. Now, chemical-induced onycholysis is often an occupational hazard, which occurs due to prolonged contact with alkalis, organic solvents, sugar, and salt solutions. So, it may be seen in patients who are food handlers or who are engaging in contact with various chemicals. Mechanical onycholysis is believed to be a result of a self-induced change, either because the patient is cleaning it or the patient is having wearing long nails or using artificial nails which act as a factor for tugging the rest of the nail plate. It's also known with acrylates. And typically, such a mechanical onycholysis has a roller coaster edge because you have different levels of penetration underneath the nail plate occurring. So, this is the typical roller coaster onycholysis. Asymmetric nail unit syndrome or AGNUS as we commonly understand it. It involves onycholysis in the feet, that is the toenails, and often occurs because of a lifetime of changes with inappropriate footwear or inappropriate gait. Nail tumors are a common cause of onycholysis. Here, a solitary nail will be affected, and more often, this is a lateral pattern. So, here you see a glomus tumor causing a straight edge or a linear transversal onycholysis. Here, you see a subungual exostosis lifting up the nail plate. So, again, you see a disruption of the onychodermal band, that is onycholysis. Photoonycholysis is an interesting entity. It is characterized by the Seagull's triad, that is, a photosensitization followed by nail discoloration and onycholysis. This is seen in patients with porphyrias or even pseudoporphyria, but more often than not, it is drug induced due to drugs which are photosensitizing, including the tetracyclines, the fluoroquinolones, nonsteroidal anti inflammatory drugs, psoralins. The most frequent feature here is that the onycholysis is going to follow the shape of the proximal nail fold. That is, it is going to be concave distally. The onycholytic edge in this case is surrounded by a red-brown pigmented zone, a result of bleeding in this area. And it is commonly a centrally located onycholysis. The lateral margin is usually spared. This discoloration is very characteristic. As you can see, the edge is following the proximal nail fold. Here also you can see. And there is a lot of hemorrhage associated with this. Another patient, this one is a patient of porphyria. The previous one was a patient on tetracycline because of acne. Here you see the presence of blisters and scarring over the hand, and this is the photoonycholysis which is occurring. The etiopathogenesis of the condition is implicated on the fact that the nail bed is less protected against photo damage due to lack of melanin, sebum, as well as stratum granulosum. But the nail plate favors a higher penetration of UV radiation, and in the presence of photosensitizers, this onycholysis develops. It has been characterized into type 1, type 2, type 3, and type 4 photoonycholysis. Here you can see the type 3 onycholysis could occur only as a round yellow stain appearing centrally with no distal communication. So there may be no disruption of the onychodermal band, but still you know that in the central location, the nail plate has separated from the nail bed. Type 4 is a severe type characterized by bullae under the nail plate. Then, retronychia is another condition in the late stages characterized by a linear transversal onycholysis, but the more proximal inflammation is going to suggest to you the cause, like in this case. Various systemic diseases are also associated with onycholysis, which is often linear transversal and involves a number of nails, a majority of the nails, in fact. So, this can occur due to drugs or due to systemic conditions like lupus erythematosus, amyloidosis, multiple myeloma, various carcinomas, even thyroid disease, which is characteristically associated with the plumber's nails, which are fourth or fifth fingernails involved with onycholysis. Taxanes are also associated with a distinctive pattern of onycholysis, also known as the Patio syndrome, or the Palmer erythema, periarticular thinner erythema and onycholysis syndrome. The endocrine disorders, as I described, the plumber's nails, and even iron deficiency anemia are associated with onycholysis. Pregnancy may also be associated. So, once we see onycholysis, how do we approach this case? The diagnostic approach relies on a complete history, thorough examination, onychoscopy, which provides us details of the edge, border, and the subungual contents of onycholysis, and then deciding on the investigation that we want. Either we want to rule out a fungal etiology or a bacterial etiology, a possibility of a contact allergic or irritant dermatitis, and then, if required, a nail clipping or a nail biopsy. This simple systematic diagnostic approach is based on the morphological patterns of the proximal border of onycholysis. So, this is the key area that you have to examine. A band-like detachment of the distal nail plate can be more often than not transversal, both partial or total. So, these are the causes which are suggested. So, within transversal onycholysis, there can be many different types. So, if you see the linear transversal onycholysis, which is the most common pattern as we discussed, the causes are either idiopathic onycholysis or other frequent forms which will occur in the initial phases only. So, these are certain the linear transversal idiopathic onycholysis. Note the absence of inflammation at all. Another patient with alkali contact, Another patient with hiking trauma, there is no inflammation and the proximal border of onycholysis is linear transversal. Here you see the presence of multiple hemorrhages because this is a case of acute trauma. Similarly, acrylic nails or artificial nails or even retronychia can present with the same pattern. Taxane chemotherapy, but here the inflammation and the surrounding skin changes are strongly suggestive towards the cause. Then, if you see a roller coaster edge, the cause is generally mechanical trauma to the fingernails because of manipulation or aggressive manicure, and this is the typical presentation. Fibrillar transversal onycholysis is a result of repeated trauma. So you have to basically look at the shoe and you have to look at the anatomical variance in the patient's foot. This is the typical presentation of fibrillar transverse onycholysis as compared to the serrated transversal onycholysis, which often suggests onychomycosis. And here, the serrations are quite different from what we saw in the fibrillar pattern. It's associated with very typical color changes. Transversal onycholysis with an erythematous border is suggestive of characteristic of nail psoriasis, but can also be seen in patients with pseudopsoriasis, which is associated with acrylate contact, acrylate allergy. Lateral onycholysis is often associated with asymmetric gait nail unit syndrome, onychomycosis, and nail tumors, as I showed you the previous cases. So these are some cases of lateral onycholysis. For example, this fibrokeratoma. V-shaped onycholysis is often a result of nail tumors, but is associated with dermatosis, that is, lichen sclerosis, Darier's disease, and lichen planus. As is seen in this particular patient, you see a typical V shape, and you see also alternate bands of erythronychia and leukonychia. Here, this is a papilloma with V-shaped onycholysis. This is Darier's. Circular onycholysis is often associated with drugs or with photoonycholysis, so it suggests you the cause straight away. It's also associated with a particular shattered windshield appearance of the nail plate. More often than not, we may see multi-pattern onycholysis, and it's a result of common nail offenders like trauma, onychomycosis, or psoriasis, where different nails are going to show you different patterns. So, onychoscopy enables proper visualization of all these changes. Characteristically helps you differentiate between onychomycosis, psoriasis, and traumatic onycholysis. Similarly, in the lateral onycholysis, it helps you differentiate characteristically. Primary onycholysis, or what we call idiopathic onycholysis, is characteristically non-inflammatory when seen on onychoscopy. The photoonycholysis shows you this very characteristic pattern of the nail plate, which we have likened to a shattered windshield of a car. Microbiological investigation, that is bacteriological or fungal organisms, depends on what are the clues you have picked up on your clinical examination and onychoscopy. Depending on that, you look for the fungal organisms or bacterial organisms. Nail biopsy and histopathology is the most specific diagnostic test or the gold standard. So depending on if your purpose is only to see onychomycosis, you may consider only a nail clipping. But a proper biopsy is required for delineating other causes, including psoriasis and lichen planus. The typical histopathology findings of the presence of fungi within the nail plate, the sandwich sign, is characteristic for onychomycosis, but the extensive neutrophilic infiltrate in the absence of any fungal organisms suggests psoriasis. Management of onycholysis, it should be treated early because secondly onycholysis persisting for a long period of time often results in a disappearing nail bed. The general measures cannot be overemphasized and are very important for ensuring the results in cases with onycholysis. Among the topical treatment options, the use of topical antiseptics, hypochlorite solution or acetic acid solution, especially in cases with pseudomonas colonization. and the use of topical steroids along with topical antifungals if required is necessary. The basic point here is that you have to keep the nails short and the onycholytic nail part has to be clipped away to ensure proper application of the topicals as well as to help the nail plate regenerate, grow further. So these are the treatment results with topical therapy only, where we can expect full regrowth of the normal nail. To conclude, onycholysis is a common sign of varied nail disorders. It is often upon us to see the cases very carefully to pick up the clues to these diseases. Careful investigations can help differentiate primary and secondary onycholysis, and optimum management, depending on the cause, can ensure non scarring outcomes. Thank you so much for your attention. I invite you all to be members of the Nail Society of India and share the textbook of onychology, which has been published by the Society. We have also started publishing the Journal of Onychology and Nail Surgery, the first of its kind journal in the world. It's an open access, peer reviewed journal with no publication charges. Please join us here and in our skill based CMEs. Thank you so much for your kind attention.
Hello to everyone. Thank you for this invitation again. And we talk about onychoscopy, longitudinal depression of the nail plate. In general, the longitudinal depression it is characterized by the presence of furrow. This is a sign of superficial nail plate. For this reason, when you have this sign, you have to think that something arrived on the matrix. This is important in the very big aspect of the typical nail sign. So how an endoscopy can help you in superficial nail sign as a longitudinal furrow? This is two cases very similar with the clinical. I think it is very difficult to diagnose. With an endoscopy, you can suspect maybe something, but at the end we have to describe this sign. One digit is involved, so think about the tumor for this reason. Multiple digits are involved, and in this case you have to think about something that diffusely happens. So this is a mucoid cyst and this is a nicotinomania. In fact, you can see all the other digits of the patient with a multiple bone line that recording that look at it, describe it as a longitudinal furrow. So the clue is the clinical history, in this case the examination. So in case of longitudinal depression of the nail plate, you have always to think about if the patient has multiple digits involved by the disease and it is especially of self-induced disorder versus only one digit. In this case, you can suspect stroma, a benign tumor, or infection. In case of benign tumor, the most important tumors that can induce a longitudinal furrow is mucosis and fibrokeratoma that have the typical position on the nail matrix, inducing this pressure on the matrix that reflect the typical longitudinal canal on the nail plate. So we have especially nail plate surface changes that describe longitudinal furrow. It's important to look at some typical signs, fibrokeratoma on the nail plate, which is also the presence sometimes of fever or onycholysis that is usually absent in mucoid cyst, for example. Both are red, and on the specific alteration, the distal mass is typical of fibrokeratoma. On the other side, we have a proximal mass. But many cases can be not so easy with the clinical observation to diagnose. Onychoscopy, in fact, permits visualizing in a better way the typical shape and contour of this furrow, and that is induced by a single lesion that is placed on the proximal nail fold. The lesion can be on or within or under the proximal nail fold, and it compresses the nail matrix. The in case of pseudomucosis, it's due to the presence of a synovial liquid that from the joint arrives with the gravity on the distal part of the digits on the proximal. They may not be evident or appear translucent or with the skin colored. It's very difficult to recognize. When there is a very important condition, important situation, you start to look at it, this shape, this edema, this alteration of the proximal nail fold, and with onychoscopy you can look at the regular linear arborized vessel on the dermoscopy. On the other side, the acquired ungual fibrokeratoma is asymptomatic, is a connective fibrovascular tissue that induces these typical hyperkeratotic tips. It's solitary, and these tips comprime again that the proximal nail fold that induce the typical canal with this central line. Onychoscopy can be very useful on the hand because these two type of lesion can be very similar always on the hand, on the digit of the fingernails. So we do this history with the comparison of 30 patients with the fibrokeratomas versus the pseudomycosis, especially when the clinical approach is not so evident as these cases. And we noticed that in our paper, in our patients, we noticed that the two big difference is especially the typical longitudinal furrow. That is completely different in fibrokeratoma versus pseudocyst. Onychoscopy, in fact, look at it with this different structure of the canal that is completely regular in its dimension and its alteration all over the nail plate along the longitudinal aspect. On the other cases, the myxoid cyst, the canal is completely irregular. Why? Because it depends how many liquid is inside the cyst and it is completely broken or not. So on the basis of the dimension of the liquid inside cyst, we can have the reflection of this dimension on the dimension and the alteration of the channel. So this is a very important, it's important criteria to distinguish it. On versus the other possibility that can induce this longitudinal furrow in rare cases, as especially the horn, the dermatofibroma, the periungual fibroma, and pyogenic granuloma. Pseudomucosis is a benign tumor. We have to recognize three different types, and it is due to the pressure of the general matrix that induces this channel. This is important. You can look at it in different with the echography to look at typical liquidal constitution of the lesion, and we have three types. The type A, that is not alteration, it's the upper in the upper part of the digit. The type B, where there is on the proximal fold on the matrix, and for this reason there is longitudinal groove, and the submatricial is very back inside, that is the only one that we have to remove with the surgical approach. The type B is the most frequent, that uses this channel with the irregular width that starts from the proximal nail fold, and we have always to observe, in fact, not only the proximal but especially the palates, where is the typical position of the lesion. So we have the nodule of the proximal nail fold and the irregular longitudinal furrow. And look at it on the clinical, where you can see the typical palates where there is the cyst. You can use also the red illumination with red light to look at the better side of the lesion. And it is very useful to have the therapeutic approach of the drainage puncture and drainage, or in the injection of intralesional steroid that induces the alpha of the case is the possibility of relapses. So, the typical onychoscopy sign are the nodule, the red purple lacune, and ulceration at right white lattice on the proximal fold, and irregular looking channel. This is important. And this irregular channel is also named as wave sign. It's due to with the dimension, the capacity, the breakage or not of the cyst that is reflected on the typical sign. Dermatology must remember that clinical findings can help planning the surgical approach. You can stop the waves, but first you may learn how to read them. Treatment. You can decide a conservative treatment with the bandage, the drainage, the intralesional steroid, or surgery. Surgery is well recommended, especially in intramatricial, submatricial lesions that is used many times also pain by the patients. It's very only really because if you don't remove completely the pedicle, it's possible to have high cases of relapses. You can see a submatricial with the complete exposition of the nail bed, and then we have to arrive in the site, and then we can cover it after with the nail plate as a biological medication to have the complete recovery. You have the typical histopathology evaluation with pseudomycoid pseudocyst, typical on the deposit of mucin on the histopathological. So endoscopy is very diagnostic. You can also perform ultrasound to better localize, but don't forget, look at the proximal part. In fibromelasoma, we have especially a centrohomogeneous light yellow skin lesion with the collar shapes around the keratin case peripherically, regular light white trace on the surface, punctate blood vessels. No symptoms again. The clinical aspect can be more broad, more dome, or aspect in some cases. And you can have also different position of this fibrokeratoma. In general, to distinguish when the fibrokeratoma is used as a channel, so longitudinal groove, it typically starts from the level of the proximal force on the matrix. And it is possible to have a big lesion of splinter hemorrhages. So we have this nodule, this is the channel that, as you can see, it's completely irregular. Look at the frontal view. It's not alteration, no changes during the prolongation of the channel. And this is the clinical. So we have an underlying nodule with a pale yellow homogeneous central area surrounded by a hyperkeratotic white skin color and possible dotted dots. A longitudinal channel. We have to remove it until the end of the deposition of the origin of the fibrokeratoma. Then with histopathology, you have the typical fibrokeratoma of the histopathology. So on ecoscopy today, it's very diagnostic to distinguish the other four. So in case of longitudinal furrow, it's always a mucosis. We have four very similar cases of this longitudinal furrow, always with this alteration on the proximal nail fold. And you can see the onychoscopy. In the first case, we have really a mucosis. In the second case, we have fibrokeratoma. What are the other two cases? In the first one, this is a word that can have this particular aspect with the nodule on the proximal nail fold. And this is a medial calaniform dystrophy of Kiel. Very rare case of a trauma, an important event of trauma on the proximal nail fold, but also you have to exclude some malignant tumors, so you have to follow these patients. So, longitudinal depression usually is self-induced disorder in multiple digit, one digit is benign tumor, oncoid cyst, or fibrokeratoma. But don't forget, possible can be infection as periungual wart. It is the typical aspect in this case is the periungual nodules that can induce this lateral channel together with the other sign of wart, keratotic papules, yellowish coloration, multiple red dots. And don't forget to think about median calaniform dystrophy of L, because on the different auto-use disorders as onychotillomania, we have only one digit involved by this trauma. It is typical of the thumbnails with this transverse region radiating from the paramedian channel, splitting the nail plate, and the typical aspect is the tree-like appearance. But it's especially due to a trauma. But you have to suspect also malignant lesion as squamous cell carcinoma. So follow the patients. This is my last talk, my last slide. I would like to thank you for your attention and invite, if you want to learn more, to study more about endoscopy, but also trichoscopy. This is the course on demand that my mentor, Professor Piracini, and I, we did it. Thank you again.
Dear colleagues, so I will be presenting now dermoscopy and surgery of the nail unit through three different clinical scenarios. I'm Nuruddin Taim. I'm a dermatologist from Tunis, Tunisia. I've specialized in dermoscopy, dermatologic surgery, and nail diseases. And these are my affiliations, and I have no conflicts of interest to disclose in association with this presentation. And in this presentation, the slides are written in French, and I will be presenting in English. This choice was motivated by the fact that I know quite well that many parts in Africa are quite comfortable, are more comfortable in French than in English, but to reach a larger audience, I will be presenting in English and I'll be showing my slides in French so that everybody could understand what's written. And I will start by the first clinical scenario. So, these are two patients, quite the same age. 20-year-old here, 23-year-old here on the left, and the patient on the right has a past medical history consistent with bone marrow hypoplasia, and she was receiving medication, eltrambobac and cyclosporin, and she has this lesion on the hallux that was evolving for 4 months. And on the left, quite the same age, 23-year-old female patient, no past medical history, however, and she reported that this lesion was present for 7 months. So, do you think that both those patients had the same diagnosis? Do you think that this is the same? And what would be the investigation you would do here in both those patients? So let's start by the patient on the right. And I think here the diagnosis is quite straightforward because she was receiving medication that would be responsible for the appearance of pyogenic granuloma. And was indeed a case of pyogenic granuloma. It was confirmed by histopathology. And here you see images from literature. And here, and as you know, the pyogenic granuloma beneath the nail plate usually present by granulation tissue, oozing, sometimes pain, and trauma usually precedes the appearance of lesion, but many medications are involved and sometimes the traumatic factor is missed or maybe not reported or insisted. And here you see the dermoscopy of two pyogenic granulomas on the skin, and here you have this clots, red clots with these white lines. And here you have this proliferation with this very suggestive keratotic colorette around the lesion. And here an image of a pyogenic granuloma beneath the nail plate. And here you see this white aspect around the pyogenic granuloma. And when you put your dermoscope, you could see quite well the white colorette. And here, tangential excision will lead to good results. And here, another case of pyogenic granuloma beneath the nail plate, the hyponychium. And you see the colorette here, you see the proliferation, and here is a clot related to the existence of a hemorrhage preceding the image. And in this patient, topical application of corticosteroids led to good results. So, the case on the left, a pyogenic granuloma. Do you think that the case on the left is also a case of a pyogenic granuloma? So, when you are in doubt, what would be the first examination you would perform? And as a rule of thumb, every time when we have a proliferation beneath the nail plate that comes from beneath, it is useful to have an X-ray to see how it works with the bones. And here is the X-ray of this patient. And sometimes you have a report that says that the X-ray was normal. And of course it is not normal. Here you see that there is something. And the incidence of the X-ray is very important, because in 3/4 incidence you have this quite beautiful image, very, very suggestive of the diagnosis. So here it is clear-cut a case of exostosis. And here, this surgical excision of the tumor. So sometimes you could suture the nail bed, sometimes you would leave the healing by secondary intention. And here the lesion was left healing by secondary intention. This is an image at day 10 post-operatively. You see how it heals quite quickly, especially in the young patients. And here after day 45 in this patient. And usually this surgery leads to good results. And the only thing that would persist is a distal onycholysis that may be persistent, like a sequela of this intervention. But yeah, let's move on now to the second clinical scenario, and also two patients. On the right, a female patient, 59-year-old. She had this lesion for 2 years, and the nail was asymptomatic. On the left, a 67-year-old male patient who had a pain and swelling of the hallux, and he has this aspect on the nail. So, do you think that those two patients had the same thing, the same diagnosis or not? And let's see how the dermoscopy would help us. Let's start by the patient on the right. So here you see the dermoscopy. And here you see clinically what's left from the nail plate, this part of the nail plate. And here, even if you are not that comfortable with dermoscopy, when you see the tissues, fibers, dust, etc., that are apparent, you are on the lesion, you are quite sure that this is a huge ulceration, because this lesion is ulcerated. And this patient had a pemphigus. Her skin lesions healed nicely, and only this nail involvement did not respond to corticosteroids. It was quite refractory, and it necessitates the injection of corticosteroids, triamcinolone. When it comes to pemphigus, here I'm showing you the results of two series. On the right, the series from Tunisia, in which I was involved, and on the left, the series from Morocco. And I'm showing you these two series because pemphigus is endemic in North Africa, especially the Maghreb region, and we have many cases of pemphigus. And what's striking is that we have quite the same results in those two series. Here, 48 cases on the right, the series from Guinea, and in Morocco, 37 patients. And the most frequent signs of pemphigus on the nail are onycholysis, paronychia, and sometimes we have other signs like onychoparesis, Bowes lines, blisters, periangle, and hemorrhage. And these are the most frequent signs. Let's see now the patient on the left. This is the picture I showed you before, and this is the image of the hallux. What is striking here on the hallux here is the swelling of the whole digit. So this is a case of dactylitis. So what would be the diagnosis? Let's think a little bit about it. The patient had nothing, no other clinical. The clinical examination was otherwise unremarkable on his skin. So what would be the diagnosis here? I think that many of you think about psoriasis, and are correct. So this is a psoriatic onychopachydermal periostitis, and the patient received initially methotrexate up to 25 milligrams per week, with small results associated with injections of triamcinolone, with temporary result, and then he received infliximab with good result. And you see here another patient from the literature, and here the patient received infliximab and methotrexate with good results. And sometimes when you would like to perform an ultrasound imaging of the nail, and I would like to show you, so this is a paper we published in 2020 about the ultrasonographic examination of the nail. And you see here, just to show you a normal nail. So the nail is this kind of 3 layers of hyperechotic layers on the dorsal aspect and on the ventral aspect. So this is the nail plate, and here is the nail bed. Here is the bone. So here is the matrix, and you see here so this is the tissue beneath the nail plate. So the nail plate bed. This is the matrix, and here is the bone. And these three layers are very important in a normal, healthy nail plate. And when you examine the nail plate itself in psoriasis, given the inflammation, the first thing that appears is a blurring of these three layered architecture or aspect, and it's the ventral aspect that becomes hypoechotic, and then the whole nail plate eventually would become, depending on the intensity of the inflammation. So this is something quite nice you would like to perform if you have ultrasound available. Now let's move on to the third clinical scenario. And also I'm showing you two patients. The patient on the right and on the left both had painful lesions that appear red. And what do you think? What would be the diagnosis? And I think most of you would suggest the diagnosis of glomus tumor. Let's see the dermoscopy on the first patient. So here you have this violaceous pinkish background with this arborizing or with this arborizing vessels that you see here, some dystrophy on the nail on clinical examination, and it was indeed a case of subungual glomus tumor. And this is maybe one of the major articles describing dermoscopy of subungual glomus tumors. It's from our friend Fatih Koktay, and it was also Professor Eckhart Haneke is among the co-authors of this article. What this article shows is that there are maybe two patterns: the pattern of the glomus tumors that are beneath the nail matrix, and those that are beneath the nail or around the nail bed, like as you see here. But quite interestingly is that the dermoscopy would help you see features that are not visible in naked eye examination in 10% of the cases. And sometimes dermoscopy will show nothing. And this is published in the Blue Journal in 2016. This case, you see here nothing, only pain is, and the love test is also positive here. And you see this is related to the glomus tumor beneath the nail matrix in the part of the nail matrix that is not visible here. So this patient has a glomus tumor, and we perform surgery, and I start by the ablation of the nail plate, and the incision is of course performed here because the tumor is very big, parallel to the lunula, as you see here. A gentle, very gentle dissection of the tumor is important to remove this nodule, not to leave part of the glomus tumor. Otherwise, we would have a recurrence. So very important to be very gentle. And you see here, post-operatively, this is the tumor. And here we suture the nail matrix, of course. We put back the nail plate. And here after the result after day 7. This is after 2 months, this is after 5 months, and this is after 8 months, and you see how the nail is healing quite well. Now, when it comes to this second patient, do you think this is a glomus tumor? So in this patient, I have doubts, because usually with glomus tumors, we don't have this dystrophy on the nail, and the Lupin test was negative, and the pain was different. So we performed an ultrasound, and it was a case of myxoid pseudocyst. I'm not diving into the details, but just to tell you that there are 3 subtypes. The type A here, very obvious. Type B, quite tricky, but you see a groove. And then the type C, that is the trickiest, which is beneath the nail matrix. And many treatment options are available. And I think that puncture, iterative puncture, and drainage of the myxoid pseudocyst is reasonable alternative as first line, And when there is no result, then we can go to surgery. And here a type A glomus tumor here, you see the dermoscopy, and here after multiple punctures did not have a good result, so I performed this the excision of the lesion and the flap, transposition flap, and you see here the aspect after 3 months, and here you have the same patient after 6 months, and no recurrence was seen after 2 years. And here another case, the type B now of myxoid pseudocyst, and you see here the groove irregular, so this is a sign that is suggesting the diagnosis of pseudocyst. And a tricky thing is to inject a methylene blue into the joint, and you see the communication between the joint and the lesion, and you suture it, and you put back the flap, and yeah, would lead to good results. So, if you are interested by other cases of nail surgery, it is good to, if you want to visit the videos that we posted, the surgical group from the Tunisian Society of Dermatology, and these are my videos on YouTube, so you can check it out and visualize those videos. And of course, for nail enthusiasts, the major educational event would be on February 8th, 2025, the same platform. All you have to do is to scan this QR code here, and that would lead you to the Global Dermatology website and to the event website. And more than 59 nail experts would give wonderful talks about different aspects of the nail. So for nail enthusiasts, this is the biggest event, and I would thank the nail societies that supports this event: the International Nail Society, the European Nail Society, the Council for Nail Disorders, Nail Society of India, and Korean Nail Societies, and more societies, including the African Society and Tunisian Society of Dermatology that support this event. And with this, I would like to thank you very much for your attention, and hope to see you soon in Tunisia.
Ladies and gentlemen, it's a great pleasure to speak about sublingual exostosis at this prestigious meeting. So what is a sublingual exostosis? You can make the diagnosis when you see a round tumor lifting the nail margin up. When it's stone hard on palpation, the surface is mostly shiny, smooth, with a color red-like margin, which actually represents the former hyponychium pulp skin border. And you usually do not see an ulceration, but maybe, and the sublingual exostosis is not painful. So this is an example, and especially showing you this color red-like border and the smooth surface, and actually this is the former border of the nail bed hyponychium to the pulp skin. And here you can see another example. And this color red is so characteristic that you can make the diagnosis in 95%. Even in very small lesions, you can see it here. This is a very reliable sign. Females are more commonly affected than males. Most patients are children or young adults. The great toe is affected in more than 3/4 of the patients. Sublingual exostosis are frequently seen in ballet dancers, kickboxers, and other martial arts performing persons, but of course also in, let's say, common persons. An X-ray should be performed both in the dorsal and lateral view, and it usually does not exhibit any surrounding destructive changes. Treatment, of course, complete surgical removal. The question is, what is a sublingual exostosis? Is it a fibrocartilaginous metaplasia from trauma or chronic infection? Is it genetic? We know there was a pathognomonic translocation TX6, P22, Q13 to 14 with rearrangement of collagen 12A1 and collagen 4A5. So this may give a hint at the fact that this is a true tumor and not only a reactive lesion. Others have speculated about supernumerary digit. Others thought it was due to cartilaginous rests or even a form first of hereditary multiple exostoses. As already mentioned, the etiology is mostly traumatic, and we confirm the diagnosis by X-ray. It's not necessary to confirm the diagnosis by X-ray, but it really shows you how extensive the exostosis is and how big the attachment to the bone, which is very important for the treatment. And if the exostosis is secondarily ulcerated or erosive, perioperative antibiotic prophylaxis should be done. We dissect the overlying skin, clip the exostosis off the bony phalanx, and then suture the skin again, and healing in almost all cases, even in very big exostoses, is extremely good. Here we have a big subungual exostosis. You see it looks almost like a mushroom. Here we have another case, actually with very little to see clinically. We have another case, again, the mushroom-like picture. And here, again, a very big case of subungual exostosis, and the clinical aspect with this color red-like border. And another subungual exostosis, and again this color red-like border to the pulp skin. And this is how the treatment was done. The overlying nail bed was gently incised, dissected, and then the exostosis clipped off with a bone, with a nail clipper. Others say they use a bone rongeur, but that's up to you. And then you see the skin is sutured with fine 6-0 stitches, and the nail is replaced. And here we have a less common localization. It's the little finger, and this is before, as we can see here. This is just 1 week after operation, and 12 weeks after extirpation, the patient has a completely normal appearing finger again. And this one is a very big subungual exostosis. You can see it also on the radiograph. And here another case of the big toe, and again this large exostosis, the classical border, and the histopathology showing the bone trabeculae and the cartilaginous cap. This shows us how the X-ray can prove that the extirpation of the exostosis was really complete, which is very important, because if you leave remnants, you will get a recurrence. This is another uncommon localization in the fourth toe, and this surgery shows how it is done. And here again, the histopathology of subungual exostosis, and here we see this fibrocartilaginous cap. And here again, in this particular case, it was painful due to the particular shape of the subungual exostosis. And here again, another subungual exostosis. We see this cartilage formation, and this is normal cartilage, and then it goes over into fibrous cartilage. And here we have a close-up of the cartilaginous cap of this subungual exostosis. And again, so this is another very characteristic subungual exostosis. This is the overlying epithelium. Then we have a narrow zone of the dermis, and then we have the fibrocartilaginous cap, and then we have the cancellous bone here. This is a little bit different when you look at the bone and fibrous tissue. This is actually not a subungual exostosis, but this is a traction osteophyte, and so we can see the histopathological differential diagnosis is possible. And again, another type of this traction osteophyte. Sometimes it may be a little bit difficult if there is no connection with the underlying bone. Then it may be difficult to make the diagnosis of either subungual exostosis, subungual soft tissue osteoma, or even distal pseudotumor. And another classical subungual exostosis, and here we see some X-ray patterns collected by Dr. Di Chiacchio from Sao Paulo in Brazil. And here we have this thorn-like pattern, and again a thorn-like pattern, and again here thorn-like pattern. This looks more like a gun, and again here, again looks like a gun. And this looks again more like a mushroom. The differential diagnosis of subungual exostosis is relatively vast, and you can read it: exostosis, osteochondroma, chondromas, pseudomalignant ossifying soft tissue tumor, osteoid, osteoma, and so on. And the most important differential diagnosis is subungual osteochondroma. And actually, there is a male predominance in osteochondroma. The localization within the distal phalanx is a little bit different because osteochondroma is in close opposition to the epiphysis, whereas the exostosis is located very distally. The radiology shows cancellous bone with fibrocartilaginous cap in exostosis, but sessile bone with scallop bone and radiolucent hyaline cartilage cap for osteochondrosis, osteochondroma. And osteochondroma is much less common. And here we have another differential diagnosis. This patient complained of a stone-hard nodule here, and then we took a radiograph, and we see that there is a synostosis of the middle and distal phalanx, and then almost a Y-shaped deformation of the tip of the what was the distal phalanx earlier. And here we can see the surgical specimen, and healing was absolutely uneventful. Another differential diagnosis on histopathology may be hepatinodes, and here you can see the histopathology really quite different. Rarely do you see calcaneous noduli. That means probably degenerative calcification in the fingertip, mainly seen in children. And this case was a very interesting case. 27-year-old female with an enlarged club distal phalanx of the right second toe since at least 5 years, and she suffered from extreme pulsating pain, particularly at night. And here we can see the toe before surgery. This is 24 hours after surgery, and she was for the first time without pain during the night. The X-ray here shows of focus a little bit radiolucent, and actually the diagnosis can even be made just from the characteristic patient history, the pain, nagging, pulsating pain at night. And here we see this osteoid-like formation in the bone, and so this is an osteoma. Another very interesting differential diagnosis was seen in this elderly lady. She had this embarrassing hard swelling under the nail, and on surgery I could take out this lobulated, very hard tumor. And here you see it again, and scanning magnification shows this peculiar lesion, and it turned out it was a chondroblastoma-like soft tissue chondroma. Another interesting differential diagnosis was seen in this 42-year-old internist. He had an oozing and sometimes tender to painful subungual lesion. This had been operated several times in the last 5 years, and he had experienced a recurrence always within 2 to 3 months. Now I did an excision down to the bone, and there is no recurrence now. And you can see the primary lesion and how it heals. And now what we see is this is the nail bed dermis. This is a little bit of proliferated hyponychium dermis, and then we see these bone formations here in the soft tissue. It is not circumscribed like an osteoma or exostosis, but it is a classical example of a pseudomalignant osseous soft tissue tumor, also called the digital pseudotumor. Other differential diagnoses are fibrous tumors, which sometimes may show bone formation, which actually is very rare in the nail region, but as you can see here in this example, and it also looks quite different from pseudo malignant ossifying soft tissue tumor. And another case here with ossification again here. So these are relatively rare in the nail region. They are much more common in the gingiva. Thank you very much for your kind attention.
Hello everyone, my name is Newton Joy Di Chiacchio and I'm from São Paulo, Brazil. And I just want to say that I'm very glad to be here, to be invited by all the coordinators and organizers of this amazing event for 2025. And today I'm going to talk about Mohs surgery for nail tumors. We're going to start talking about malignant nail tumors, but before that it's important to remember that when we are talking about Mohs, the most important outcome that we must have in mind is the oncologic outcome, which is represented by high cure rates, and then we think about the functional outcome, and then about a cosmetic outcome when we indicate this type of surgery. And talking about BCC, we all know that's considered a rare nail tumor due to the lack of pilosebaceous units that are in this area. And with that, we have a very bold clinical presentation with no specific manifestation. And for those even for who are nail experts, it's not easy to do this diagnosis, and mostly they are cases that are misdiagnoses, especially for GPs or general dermatology. And these are the cases that is reported in the literature where they performed the most surgery to treat these two diseases with very good result, not only oncological but functionally, since the digit was not amputated, and a very good cosmetic result. And this is a case where I performed the most surgery for a periungual BCC with two stages, as you can see here. The healing was by segmentation. This is the aspect after 3 weeks, and then with the total healing of the proximal nail fold after 2 months. And this is another case where I performed the most surgery of a periungual BCC. This is the final aspect after the surgery with a skin graft, and then here after 60 days with a good outcome oncological. This patient is over 5 years of follow-up with no recurrence, with a functional result, but of course we could not preserve the nail matrix, so with this cosmetic result not achieved. And then when we talk about SCC, when we go through literature, we can see since we have no bone invasion, MOS is a very good option for the treatment. This is a very good paper, although that is almost 10 years that has been published. I like to show that because they have a good number of patients and a good number of follow-up. They reinforce that MOS has high cure rates for the treatment of nail SCC, reduce the number of unnecessary amputations, since it so improves the patient quality of life. But more than that, they say that most surgery allows the evaluation of periosteal invasion and for bone invasion to be reliably distinguished from inflammation or compression, which sometimes we can be a pitfall for us. But the problem that we must remember is that technically it's not that easy to do that bone evaluation during the frozen sections. And this is a more recent publication where they compared all the publications that we have, the recurrence rates, and more than that, they show that most of the cases that have been recurrence, they have the RUCA features, and that is being published in more publications when we look for that in the literature, and what we see that the HPV association is associated with more staging for both to achieve the free margins. And more than that, they are more related with younger patients, small lesions, and less infiltrative lesions. And when we go through literature, we can see that doesn't matter if you are for a wide excision or most, both has low recurrence rates, both have good results, oncological results. But we can say that one technique is better than the other. We need more studies, prospectives, comparatives, randomized and controlled one. And this is another publications where they reinforce not everything that have been said, but that the most surgery has the advantage of the intraoperative evaluation of histopathologic analysis of the bone to do the differential between inflammation and invasion. So this is very important. And this is a more recent publication where they show the benefits for most micrograft surgery for the lesions that have the HPV association with malignancy. And for more than 700 cases, they found that 100 cases around of nail and digit SCC that were submitted for both surgery, they have a recurrence rates of almost 10% and a follow-up of almost 50 months. And these are some cases where I performed the most surgery to treat this invasive SCC. This is the final defect just after the surgery, after 30 days, and this is the picture after 5 years of follow-up. And this is a case, a young male with 32 years old with a recurrence invasive SCC. This is the final defect, and this is after 3 months where the healing by segmentation has been completed. Just a little bit of nail plate, for a man doesn't mean so much, but sometimes for a woman it's good to have to save this little part of the nail. Maybe it can be used as a substrate to put a gel nail or even acrylic nails. So it's better to keep it. So this for this case, oncologic and functional result perfect. We did not go went to amputation, but as a cosmetic, as I told you, not the best one. So we must take care how we put the technique for the patient, as we would save the nail or these noble areas that the technique can come. And this is another case when we clip this nail plate, we can see that we have this lesion that were submitted by a biopsy and confirmed invasive SCC. This is the Mohs surgery with 2 stages, and this is the clearance of the margins. And this during the follow-up, we found this nail spicules, so we saved too much nail matrix. We just remove it, and this is the follow-up period after 8 years. And in this case, we can see that we have a moderate invasive SCC, as you can see here and here, a more aggressive one. And during the follow-up, after the 3 years of Mohs surgery, he presented not only clinical signs of recurrence, but radiological signs of the bone invasion. So for this case, when we have bone invasion, so amputation is very well indicated. And so I like to show this case where we have an in situ lesion, this bone disease affecting the lateral and the distal part of the nail folds, where we could theoretically even apply for do conservative treatment, but I don't like too much. I prefer surgical excisions, and in this case I performed the Mohs, and this is what we got after 3 stages. So we must take a little bit of care and caution when we are dealing with SCC. And what these two cases has in common, the HPV. So we must pay attention. Recurrence for those cases, usually they happen in poor differential tumors, or when we have compromised surgical margins. But we must remember that HPV is the most frequent etiological factor, and the surgical margin, the tumor margin, is not necessarily represented by the viral margin. Sometimes we are thinking about the vaccination or the use of NICMO during the postoperative period. And then we have the melanoma. It's important to remember, even if you are going for Mohs surgery, it's important to say to the patient that the removal of the entire nail unit is necessary, although we are preserving the lesion, and it's very well indicated for, especially for in situ lesion. These are some cases just after the surgery and during the follow-up. We have a new publication showing 14 cases of in situ melanoma that were submitted for Mohs surgery with a 10 years of follow-up and 1 recurrence. They reinforce the use of immunostains, especially MART1, and technically for process all these specimens during for frozen sections, it's better to keep the nail plate attached. And this is a recent publication showing that there is no statistical difference between local recurrency, between Mohs and wide excision and amputation. So amputation does not save the life when we compare with the Mohs or even the functional surgery. So for melanoma, it's important to remember that all the nail unit will be removed. It's better to keep the nail plate to process these specimens in the frozen section. Remember that we have to use immunostain, especially MART1, and even considering the paraffin after the Mohs surgery. Remember that we are improving patients' quality of life since we have low amputation rates, and it's very important, especially for melanoma, not only the nail surgery skills but pathology experience. And we must remember that for melanoma we have some field cells that are responsible for local recurrence. So is it most the best technique to treat a melanoma unit melanoma, since we can have these field cells? It's difficult to say until now. And then we have onychopapilloma, but onychopapilloma is a benign, but we have some malignant ones. And this is a publication that has come recently where they submitted a malignant onychopapilloma for Mohs surgery. They use the HPV stands to do the differential diagnosis and the Ki-67 to help with the analysis of the margins. And then we have the indications for the benign nail tumors. The point is that when we talked about it's important to keep the indication recommendation for most for an oncological purpose to achieve high cure rates, to treat the tumor. Of course, if you can functionally preserve the digit, perfect, and then a cosmetic result. The point is that sometimes for benign tumors, this technique is put otherwise. They reinforce the use of the technique sometimes to preserve noble errors and forget that sometimes it's not that possible, and we are going to see that. So subungual keratomatoma is another indication to treat this tumor with Mohs surgery. This is a case that is reported in the literature. This is a case where we performed and just after the surgery to stage, pre-margins, and this after 3 years. And as you can see here, the bone reabsorption after the removal of the lesion, they become normal, as you can see during the follow-up period. And then we have the publications with superficial arc of myxoma using Mohs to treat this tumor, as you can see here, with a very good, not oncological and functionally, but with a good cosmetic result. And this is a case where I performed. I could not save the nail matrix. The patient is free from the tumor, but the nail matrix, unfortunately, just a little bit of nail plate. And then we have glomus tumor. We have this publication showing the use of this technique to treat good cure rates, but the point is that technically it's very difficult. When we do that, we have more stages to achieve the free margin, so it's not a good option. And when we put together this other publication, we conclude that it's not the first choice, the most to treat the glomus tumor, maybe can be indicated for recurrency tumors. And then we have onychomatricoma. These publications, they show that the technique could be used to minor trauma in the nail matrix. This is the result that they got. And these are those cases, two cases when I performed the Mohs surgery to treat these two onychomatricoma in the same day. This is two tumors with the same aspects, and these are the two results that I got. One good static result, the other one apterygium. I could not save the matrix. So it's difficult to say that for benign nail tumors, although the technique can achieve clearance of the tumor with low recurrence rates, we have a minimal removal of the non-affected nail matrix, bed, and folds. But even that, is it most really needed for benign nail tumors? And since we have economic factors involved, I don't know, maybe not. And to finish this presentation, as a take-home message, it's important to remember that although we have the publications showing that Mohs has very good high cure rates, we can't say that for sure because we have only publications of single centers. We do not have randomized prospective and comparative studies. And it's important to remember that especially for malignant nail tumors, they have the technique can achieve high cure rates, allows the intraoperative evaluation of periosteal invasion, improves patient quality of life since we have low amputations, and for SCC, must remember that the tumor, the surgical margin, is not represented by the viral margin, and the subungual melanoma, we have diffuse cells. Thank you very much for your attention.
Hello, what a great nail session. Thank you, Chander, for being with me and sharing this session. I have a question for you. The first question is for you. So you presented about onycholysis, and the question is the lateral onycholysis that is the most fearful type of onycholysis. What especially do you recommend besides all you have presented in your lecture?
Thank you so much, Matilda. The lateral onycholysis generally is going to be a part of distal lateral onycholysis, but as I spoke during the talk, when it is more or less lateral only, then you should always think in terms of nail tumors and even asymmetrical gate nail unit syndrome as possibilities, in addition to the other causes that we are looking at. And the more important thing here is the use of microscopy by the dermatologist, because it helps you pick up, really helps you pick up the subtle clues about the tumors as well as even psoriasis and onychomycosis. Also, I specifically tell the patients to not keep cleaning up that area, because this is a common tendency, especially in the great toenails, the larger nails. We often see that there is some degree of lateral nycholysis, which is aggravated by the patient cutting that part of the nail and cleaning underneath it and producing symptoms for themselves, which are easily avoidable. So, this is something which I tell the patients often.
Correct. I totally agree with you, and always when of course the tumor is the most fearful possibility. I also try, if it's feasible, to remove the onycholytic nail plate, because sometimes even with dermoscopy you are not really able to look under the nail plate surface. So if there is the possibility, also cutting the onycholytic plate, it's helpful to reach a final diagnosis.
Yes, yes. Just to reinforce, you rightly said, cutting away the onycholytic part of the nail plate, it's important both for diagnosis as well as for management when we are dealing with the onycholysis. So once it is removed, you can see better, because otherwise the air interface is not going to let you see. And secondly, the patients can apply their treatment, their topical treatment better. And that topical treatment can work in that area instead of that plate staying there and tugging on the rest of the nail plate and pulling it off also. If you let the onychized nail plate stay there, there are chances that the onycholysis is going to worsen further, because that free nail plate is going to tug on the rest of the nail plate.
Agree.
Then moving on.
I have to admit that when I see a patient with onycholysis, I'm always scared, because it's so difficult to cure patients with onycholysis, especially if onycholysis is something chronic, maybe due to housekeeping works and everyday trauma. So I sometimes tend to lower the expectations, because it's a sign that it's mild, but it's very difficult to manage and to treat. Because we use hands and feet every day. That's why also nails are so difficult to treat, because the everyday trauma worsen every effort that we make to treat and to cure patients.
Right. So next, there is a very moving on to the questions related to trachonicia. Matilda, you've told us completely about the spectrum of trachonicia and the various associations. There's this question about the use of alitretinoin, because I suppose this drug is not available in many countries, including India. We don't have access. You specifically have good experience with alitretinoin.
Yes.
So if you could tell us more about this drug.
Okay, so in Switzerland and in Germany, I have to admit I'm not aware of how many countries are allowed to sell it, but Germany and Switzerland, and I spoke about Germany because as Swiss, we can also take advantage of the German market regarding to drugs. And it's sold for eczema. That's the reason why alitretinoin is marketed, and I like it because it's effective as acitretin, but with less side effects. So we know that for nails needs time to improve. Okay, and acitretin is a slow action drug. So the time that you need to achieve results, maybe it's too much, and the patient develops side effects. With alitretinoin, maybe since it's slightly less potent than acitretin, you need one more month or two, but the patient do not develop side effects. And so they can keep going without any issue. Most of the time, the lipid panel increase, but you can manage it, okay? Not necessarily prescribing statins. You can make a stop and then a restart. They can control the diet. I think it works. But what I like is that I really can prescribe it without having the patient back in my office every month complaining because the skin is too dry and they want to stop, or they stop the drug by themselves. They don't tell you that they stopped, and you see them maybe years or months after worsened because they stopped without telling you. I think it's safe, it's easy, and of course all you do, all the lab monitoring that you do for acitretin, you have to do it with alitretinoin. Is the same.
Yeah. Okay, perfect. So hopefully we all have it available someday, and we'll be able to take advantage of the advantages of the drug. You also spoke about the topical JAK inhibitors in drugs.
Yes, that's what I wanted to say. You have better drugs than alitretinoin. So don't be concerned.
Absolutely,
Because yes,
advantages of being in India.
yes, I have been a huge fan of alitretinoin, but I am sorry for alitretinoin itself. Now I moved to be a groupie of topical JAK inhibitors. I think that in lichen planus, more than psoriasis, they are really a game changer. Because they improve without side effects. The only thing I need, I'm not really happy with, is they should be applied twice a day, and they should not be washed off after 2 to 4 hours. So I'm only concerned about the morning, because if you have lichen planus or trachyonychia, most of the time all the tan nails are affected, and not washing the hands for 2 to 4 hours nowadays can be a problem. But I think that patients are very motivated, and so at least my patients, they have no problem, and I see the disease improved really impressively.
This is topical to axitinib that you're talking about, or any other drug?
That's the only one that I have. We have the compound, and we will have soon topical dermoscopy. So it's already available in Germany. As I said, it will be available in the next few months. It's sold for hand eczema, and basically it is a pan-JAK too. So I suppose it will work as well as topical tofacitinib. I had the chance to try topical ruxolitinib that is sold for vitiligo, but I didn't have the same results as tofacitinib. Like it's less potent, and the inflammatory infiltrate is not exactly JAK1, JAK2. So maybe, but maybe, and I have no proof of that, is also a problem of penetration, because the vehicle of ruxolitinib is not the same of tofacitinib compound, is not the same of the marketed tofacitinib that you have, and is not the same of delgocitinib. So what I really would like to see, I'm not able to do them myself, is penetration studies. So to study not an active principle, but a vehicle that is able to reach the matrix. That's what I would love to, because they are all thought for skin.
Yes. So you ask the patients to apply on the proximal nail fold area?
Yes.
And how long you had a follow-up? How long follow-up? And
I see them every 3 months in my practice, but I ask them to send me, this is for my personal, a picture every month. So I track them, so I can really follow them, but they really go fast. In 3 months, 3 to 4 months, they are almost cured. Of course, they have to keep going. There is no
Very
way
nice.
to taper the drugs, but they do it because they are happy.
They are safe. Yeah.
Yes, they don't have to ingest pills. They are scared of having side effects, and especially old people, because lichen planus, at least in this area of the world, is quite common in middle to old age. We don't have so many children, and the oral jugs has an age limitation. So over 65 years old they cannot. So that's what a really a game changer for me. Yes, you have to start using it a lot. I am
Encouraged by your response.
Yes, there is one more question regarding the presentation of Nilton Gioia Chiacchio regarding Mohs surgery. So basically, as you was able to listen, he said that there are not study yet. They say that for squamous cell carcinoma, Mohs is superior to wide excision. And I don't know, because we are not in my department. Mohs is not allowed for nails, so it's just for face. So I want to know if your opinion is the same. So I don't know if you do Mohs or regular surgery. You do regular surgery only.
Yeah. We don't have access to more setup as of now. Like in Delhi, the All India Institute of Medical Sciences have started doing more surgery, and they have not moved to nail as yet. One key message from Nilton's this thing presentation, which I perceived very rightly, was that the cost may not be justified for benign tumors. And as you're saying, for squamous cell carcinoma, and the results that he was showing, I really found that very interesting, in case whatever part of the tissue can be saved and recurrence can be minimized, then Mohs should be serving very well in this area. And the basic principle of Mohs being that, it's a controlled excision, and that becomes very important in a appendage like the nail, where you want to preserve as much of the anatomy as you would be able to give the patient a functional digit. So I think it should be, should be studied more in the centers which are doing more surgery. Though I personally don't have experience regarding that.
Yes, I do neither, but I totally agree that the function should be preserved as much as possible, and also patients should be aware that when they have something in the nail is not the same that having something in the skin. Because removing a squamous cell on the back or on the face is not the same that removing in the nail. And I have also a question for you. You didn't talk about this in this presentation. If you do surgery, or you have a patient with receiving surgery for a squamous cell carcinoma, if you advise the patient to do the HPV vaccination as a kind of to prevent recurrences.
No, not as of now. With this rising awareness about the presence of HPV subtypes in this area, this might be, a future thing that we do routinely, but not as of now.
Okay.
As of now, we are not seeing that much in India. That much squamous cell carcinoma is not seen in the nail unit,
Okay.
and we have not specifically studied the association with HPV. So though we see a lot of warts, we don't see squamous cell carcinoma. Maybe the HPV types are different, but then we don't have typing, so access to routine typing. So maybe we don't know also.
Okay. So, do you have any other question? Otherwise, we are done. I don't know if you have questions or not.
There was this question about the nail involvement in pemphigus, which Dr. Nuruddin has shown. So the question is like, how often do you see nail involvement in pemphigus? He had shown just one nail involved, and rest of the lesions were not there. What's your personal experience, Matilda?
So, as you know, in the northern part of Europe, we do not have so many cases as they have in not in Africa. They in northern, especially
Yeah,
they
you mentioned it's endemic. Yeah.
especially the foliaceum. So I have patient. I don't have many cases. I see sometimes nail involvement, especially in older patients, and I have to admit that is so a specific. What I see, that I'm not really true that is due to pemphigus or is onychodystrophy due to age, abnormal gait, or something like that. But I always suspect pemphigus when I see erosive lichen planus. So I put pemphigus and erosive lichen planus always in differential diagnosis, but in every case of mine ended up to be lichen planus and not an erosive pemphigus. And I had very severe cases, but the nails were most of the time spared.
So, yeah, in our scenario, we have not seen nail as the presenting sign of pemphigus. That's not the initial site. But generally, we have seen nail as a very recalcitrant site of pemphigus, as in the skin will resolve and even the mucosa, oral mucosa will start improving post therapy. But nail takes a long time. The paronychia, the erosive changes head, this takes a long time to resolve. And whenever a recurrence is occurring, even then, this is the site which aggravates first. This thing we have seen in some of our patients with pemphigus, but only in a minority. It's not a common thing to happen.
Okay.
Okay.
Good. If there are more questions, feel free to send us by email. We will be happy to reply. And see you next year, I hope, at the next edition of this wonderful meeting.
Definitely coming up.
Thank you. Have a nice evening. Bye. Bye. Bye.
Bye. Thank you so much. Bye.
because otherwise, if you stop the drug. Very stubborn. It's and it's very stubborn also event. You can see the
Hello, I'm Professor Frederick Coe. I'm head of the Department of Business. And usually in this type of involvement, you can have some very